Now, Allan Jaffe and Dr. Ileana Piña, Associate Chief for Academic Affairs at the Montefiore Medical Center in New York City, discuss recent lessons learned from the HF Action trial.
Welcome, Dr. Piña.
Thank you.
Tell us a little bit, so we have background, on what type of trial the FH Action trial was and what the results were before we go into the topic for today, please.
Thank you. So HF Action was an NHLBI-sponsored study of 2,331 heart failure patients, New York Heart Class 2 through 4, who were optimized on medical therapy, and I need to say we had excellent background medical therapy, and were randomized to an exercise intervention versus control. Control, however, did include extensive patient education. It included phone calls in parallel to the patients who came to the center to exercise, and our endpoints were all-cause mortality, all-cause hospitalization. That was our primary endpoint. And we had several secondary endpoints, including mortality and heart failure hospitalization, mortality and cardiovascular hospitalization. We did the Kansas City Cardiomyopathy Questionnaire. We had peak VO2s, 6-minute walk. It's a wonderful database full of wonderful information. And in our results, we had a very modest reduction in the endpoint, which was not statistically significant, but when adjusted, and this was a pre-specified adjustment for prognostic factors, it became significant, but it was still very modest. The endpoint that showed the best benefit was the endpoint of mortality and heart failure hospitalizations. And so we went ahead and we have done the on-therapy study to see if, in fact, the intervention had an effect. And it did, even though this is a post hoc analysis, it did have an effect, and we presented those data at the ACCEL last year, and the manuscript is written and it's been now submitted for publication.
If I might ask, when you say on treatment, how much exercise did they need to do to be considered on treatment, and how big were these differences?
Our exercise therapy was targeting a 70% of a heart rate reserve. The patient started in a supervised setting, a rehab center, 2 to 3 times a week to start with, working up to 3 times a week, and up to 30 minutes of exercise with a warm-up and a cool-down. After 6 to 8 weeks of coming to a center, they were transitioned to home. And the NHLBI paid for a piece of equipment, either a treadmill or a bike, in the patient's home for the patients who were randomized to the exercise group. And then it was continued for 2 years. We had things like diaries for patients to write down what they were doing. A subgroup of patients had polar monitors that would monitor their heart rate. We had phone calls to both groups, again, to encourage them to keep exercising. We gave them the option if they felt that maybe they needed another little training session to come back and do a training session with us. We did not demand ECG monitoring. It was totally up to the site.
To be considered on treatment, do they need to adhere to 50% of their exercise or 75%? And what percentage of the group met whatever metric you used?
Right, so we didn't have that metric early on. We put that metric in toward the end when we started to look at the data. But what I can tell you is that you can see that even in the supervised setting, already the adherence is below what we expected. And as the trial went on, you can see the adherence dropping. So so-called trial fatigue, perhaps, on the part of the patients. And in the paper, and I don't remember what our cutoff was, we talked about moderately adherent, very adherent, less than moderately adherent, and not adherent at all. So we divided up into quartiles. And by the quartiles, in our initial presentation, we did it by MET level, so how much work. And the benefit is there. It's interesting because it doesn't take a lot to see some benefit, which I think is helpful, but that'll be in the publication.
Why do you think people didn't adhere? Were you not as supportive about some of the things that you needed to be, or are there other parameters that we should consider?
Yeah, so we had a lot of cardiac rehab experts working with us either at sites or on the executive committee, and we realized that there are barriers that exist for patients. For example, transportation, having a spouse at home that needs care, not wanting to leave the spouse, childcare issues for younger women. And so we try to remove the barriers. I know in my own site, if they needed a taxi cab fare, we paid for it. If they needed money for childcare, we paid for that. If they came to us, we had a parking sticker to give them. And we found satellite centers that would be close to the home. So the distance back into the city where parking is difficult was not a barrier. And then, of course, the exercise people got a piece of equipment in their home for free. And they were very nice pieces of equipment, very nice treadmills, very nice bikes.
So this sounds like you removed a lot of the barriers. So do you think this had to do with the providers or trust of the providers? Or were there differences between genders? Or what are your thoughts about that?
Yeah, I don't think it was trust of the providers, because I think that most sites like myself used our own patients in clinic who were people that knew the team. They already trusted us. We had been caring for them. And on the contrary, I had very few problems getting patients to consent to be in the trial. Because here, this wasn't a drug, so it wasn't another pill they had to take. Patients hate to take the next pill. And so I don't think it was trust. And we have to finalize our women outcome data, but we really overall didn't see a gender interaction in adherence. I've thought a lot about this. And I thought that we as clinicians, and the shorter time we have to see patients, don't have the time to spend getting into the culturally sensitive issues about the patient's lifestyle. What about the family? And I think the best example I can give you is I'm, of course, Hispanic. My mom never thought about exercising. Certainly my grandmother never did. I do. But you have to understand that, for example, a Hispanic woman will go back and ask permission of her family to do it. And if the family supports it, then she would probably do it. She may not finish the program, but she'll probably do it. If you're asking patients to exercise in an unsafe neighborhood, they're not going to do it. So I think that we as clinicians need to, in the short time that we have, or with our ancillary help, with our nursing and our pharmacists and our physical therapy people, to get to understand the patient's social situation, their health beliefs. Do they believe that doing this is actually something that might be helpful to them? What are their goals in life? You know, I've had patients who just want to get to a daughter's graduation or a son's wedding. And so one way you can say to them is, I want you to get there, and I'm doing my best to get you there. And so we're going to take good care of you.
It sounds like you're moving toward the psychology and the socioeconomics. And I'm wondering if you had any data in your trial that reflected on those parameters.
Yeah, we did not collect socioeconomic data. We did look at regions of the country and really didn't see many differences, thinking that maybe in a more crowded area like the Northeast, it was more difficult, and in areas where people live healthier lifestyles, and we really didn't see any changes. And so I think that there's just something inherent in the human about adherence that I wish I could understand better. And, you know, now that I've read a lot more about health behavior, trying to figure out where the patient is in their health behavior beliefs, and are they ready to make a change? Do they see themselves as being able to do this? And, of course, it's called self-efficacy. And I think we need to engage in these types of trials, more behavioral scientists with us when we want to do these larger trials.
Well, I have a little bit of an interest in depression and heart disease. Do you think depression plays a role for these individuals?
You know, we did get the Beck Depression Inventory, and the score was one of those prognostic factors that we adjusted for. But when we got right down to it and started to build a model on adherence, it fell out.
So what are the lessons, both for our attempts to improve heart failure patients as well as for the clinician, that you'd like to share?
So I'd like to say that exercise is safe. And I think this trial proved it. We had no excess adverse events at all. And that it can be done, that you may not need ECG monitoring, and that hopefully it can be adapted to the setting where the patient is in their life. And perhaps rather than using the word exercise, the word activity may be easier to swallow. If they don't have to set aside a time to get on a bike and get hooked up, but rather go out and walk with a friend and set up times to do these together, finding strategies and we're doing this at the American Heart Association, certainly in the college talks about this, making it easy for people to do the right thing.
Well, hopefully, when you have even more solutions and some more data, you'll come back and share it with us again.
I'd love to.
Thank you very much.
Thank you.